the second part, I wanted to talk a little bit about some of the criticisms of ACT and some of the concerns with ACT. So it's not a panacea. It's not the perfect model. There have been some concerns brought up. And talk a little bit about those. And then talk about how we might integrate ACT with ideas of recovery. So ACT as a model was developed in the 1970s before we were talking about consumer empowerment and consumer-directed care. And so some of the aspects of the model seem to be in conflict with some of recovery principles. And so how can we do that well? And that's been something that's been very near and dear to my heart, is how to do that. And then as Ori mentioned, really ending with more of a discussion about how it might work here, that I don't have the answers. I don't know your culture as well and your funding and all of that. And so to hear from each other and to kind of talk about what challenges you see and what opportunities and what you might take from this and what it might look like. So some of the criticisms or concerns have been, will it work here? Well, it's great that it worked in Madison, Wisconsin. Madison, Wisconsin is a very small, liberal university town that had a lot of resources. And people said, well, it's not going to work in this city or this rural area or this country. So that's been a concern. Another concern, it's too expensive. We can't afford to do ACT. You have all of these high-paid professionals meeting every day. You have small caseloads. We can't afford to do it. And then, is it really recovery-oriented? Is it really helping people with recovery, or are you just controlling people or managing them? So those have been the main concerns. The first one, really, in the 1990s, I think people started writing from other countries, especially in the UK. They were saying, our studies of ACT don't show that it's as effective as your studies in the US. They don't seem to be as strong of outcomes when you look at ACT in the UK. And part of that seems to be that their mental health system was better than ours to begin with. So people weren't in as much of a need for ACT as they were in the US in the 1970s with all the fragmentation. So that's something to think about here. What are your baseline services? Are your clients doing well? Or are you seeing a lot of struggles with people coming in and out of the hospital? Are they homeless? Are they using your shelters? So we need to think about those things. Another critique has been that a lot of the evidence supporting ACT was when we were using hospitals a lot. And now, even in the US, you see more community-based care, more team-based approaches, even though they're not doing the full ACT model. So maybe care is getting better. There's also been some concern that ACT doesn't really work in rural communities where you have not the great population of people in one area. So how do you have these intensive services when you're in rural areas? And in the Netherlands, the Dutch have come up with a new model called the function of ACT that they have used. And what they do is they offer clinical case management to all people who have mental health concerns. And when a client is in crisis, then they pull together a smaller, more intensive kind of ACT team to provide that extra care and those extra services. So it's like a mini team is embedded. And then when the crisis is averted and the person is kind of back, then they can go back to regular services, which might be every 2 weeks, or maybe once a month, depending on what the client needs. And so there are some readings here that I have that you could kind of look to that. There may be lessons that you might take from the Dutch FACT model or okay, it's not, there we go. So some of the issues are then to think about where do ACT services fit in your larger mental health system. So I don't know what all services you provide here. So I had some conversations at lunch about some of the services that are happening. So when we get to the discussion point, I would love to hear from you about what those other services are, and do you see a role for ACT somewhere? I think what we can learn from the Dutch is then how do we decide who receives ACT services? So if you have a larger team with larger caseloads, then how do you decide when is that crisis point where you're going to bring in that smaller team and work more intensively? And you would, in your organizations, have to identify your own kind of system of when do we come in with a more heavy hand. And then how do you decide when people don't need those services anymore? So kind of creating that your own system for knowing when does someone need this intensive ACT model, and when do they need just a more regular case management or check-in kind of system. So the second concern, ACT is too expensive. So there have been a couple of studies on ACT costs, but not anything really recently. So Eric Latimer did kind of a meta-analysis of multiple studies and put them together and found that ACT really saves money when you're using it for the most intensive service users. So in his studies, people who were using like 50 hospital days or more a year annually, that's when it kind of saved money. He also found that it saves more money if you're following the model more closely. So depending on how well you're implementing the model. And I don't know in Israel how much it would cost. The last figures I saw in the United States would be approximately $12,000 per client per year. And so to run an ACT team. And so then an administrator would have to think about, well, does that offset the cost that they may be costing us in emergency care services, in hospital use, crisis services, and those things. So when we think about cost data, some of the limitations, we haven't really had a lot of recent cost analyses, so I can't tell you, based on last year's costs, what it would be to run an ACT team. Psychiatric hospitalization arguments, people are using hospitals less in general, at least in the U.S., I don't know here. So that argument is not as compelling to administrators now. Where it's happening in the U.S., people are ending up in our jails and in our prisons, in our physical health care facilities, emergency rooms, not so much in the mental health care facilities. And so those other areas are getting the costs. And then in economics, the principal-agent problem. To whom do the costs matter? So if I am an administrator and I'm responsible to pay for these services, but someone else pays for the hospital care, and someone over here pays for the jail system, there's no necessary benefit for me to change what I'm doing over here because it's not hurting me. The costs aren't hurting me. So that becomes a problem. Who cares about the costs? Who cares about the services? And getting those people in the same room to coordinate how you want to do things. And so those are things that we need to think about. And maybe in the discussion we could talk about who are those people who need to be in the same room talking and kind of figuring out the costs. And then another big criticism has been, are ACT teams recovery oriented? So if you're maintaining fidelity to ACT and following that model, can you also provide individualized care? Can you also do things that the consumer wants to see? Can you be consumer directed? Can you focus on their outcomes? And can we be recovery oriented? And there, in the early 2000s, there were several articles about this concern that we're hearing that we should support recovery, but the ACT has a certain model, and you're supposed to see everybody so many times a week. You have to see them in the community. You can't take no for an answer. How do you balance that out? And so some of the tensions, too, we have something called outpatient commitment. I don't know what that looks like here, where legally a judge can say, okay, so you have that same thing. So legally, you have to get treatment. Well, how do you do that and be recovery oriented? Can you control living arrangements? Sometimes ACT teams would be responsible for the housing, especially homeless ACT teams. Well, ACT teams who serve homeless people, they would manage the rent or the lease, and so they could be in control of a person's home. Sometimes ACT teams use injectable medications or even daily medication checking. Are you taking your medicine every day? And so that may contradict a person's choice to say, I don't want to take medication. And so how do you balance that between ACT and client rights or consumer rights? And then this idea of the representative payee I mentioned earlier. Sometimes ACT teams would manage the person's money, and then they become that gatekeeper or kind of a control function. And I have been to ACT teams where they would hold back money that was the client's own money, but until they came to treatment or they came to group, they would not give them the money. And so some places would use that as a control mechanism. So because of all of the concerns around whether high fidelity ACT teams and recovery can be compatible, we actually did a series of studies that they were funded by the National Institute of Mental Health to kind of see how could we integrate ACT and recovery. When our center was doing a lot of training and technical assistance, we would visit ACT teams, those 32 ACT teams. And you could walk into places and feel like, wow, they really get recovery. They really support consumers. And you would think, I would want to be treated here if I came here. And you could go to other programs that felt very controlling and kind of paternalistic and maybe less appealing to be at. And we wanted to understand how could those teams still do the ACT model well, but also support recovery, that we thought it was possible, but we weren't sure what is it they're doing differently than these other teams. And so what we did, we identified 4 teams in Indiana that all had pretty good fidelity scores. So using that scale I talked about before the break, that they were averaging 4 or above out of 5. So they had to be meeting a minimum level of fidelity. And then we took kind of an extreme groups design where all of our consultant trainers who were visiting the teams rated all the teams on different dimensions on consumer choice, whether consumers were involved. I think we had like 4 or 5 different items, and they rated them all. And then we took the extreme teams and we invited the 2 most recovery-oriented teams and the 2 least recovery-oriented teams to be involved in our study. And so then we spent 6 days of site visits over maybe a 6-week period. We would go visit them. 2 people would come at a time, and we would just hang out. We would observe their morning meeting. We would interview staff, interview clients. We did surveys. It was sort of like a mini ethnography. So if you're familiar with anthropology, it's very many. It's only 6 days, where usually anthropologists might spend a whole year with a group. So these were many ethnographies. And we did all these different types of assessments where we did the surveys. We did observer ratings, all of the people who went to visit. We looked at treatment plans and made some ratings on recovery orientation. And we asked staff and consumers to make ratings. So we had a little checklist that matched each other, where a staff person and a client would rate the same thing. So based on this visit today, how much choice did I have as a consumer? And we would ask the staff, how much choice did the consumer have in what you did today? And we asked these ratings, and we gave them envelopes that they would return them back to us independently so that the staff member wouldn't see what the client wrote. So we looked at those. And then we did interviews with staff and consumers at each of the sites. So then we tried to identify from all of that data, what would differentiate those teams? What made the difference between the really recovery teams and the not so much? And what we found were 4 basic things. So something about the team culture, and I'll go into more of these in more detail, but how the team interacted with each other and what their culture was like, the structure of the team, kind of the environment they were in, and then how they worked with consumers. And that there were elements of each of these that really differentiated the really recovery teams from those that were not. So the team culture. Teams that had the high recovery-oriented nature really trusted consumers. They assumed that people can handle their daily lives, and they would only step in later. So they assume that people can handle their medications. They assume they can handle their money. And then if there's a problem, they increase the services. And the staff on these high recovery teams actually said things like, we're not their parents. We're not here to control them. Like they made those kind of comments. Whereas the other teams did see themselves as parents, that we have to take responsibility, we have to control things. So it was a very different kind of, where is the trust in the relationship? The high recovery teams had more positive expectations for consumers. They actually talked about how they were working with people to graduate, that people would no longer need their care, and really assuming that people could achieve their goals. And the other teams were more cynical, like not really thinking that people could reach their goals. One of the clients said that she asked them about graduating, and they said that would never happen. So she was actually told, her perception at least, was that she wouldn't ever be able to graduate. So it was a very different kind of expectation. The positive teams were much more about celebrating successes and less judgment. The morning meetings were more positive about consumers. And they were very cohesive and respectful of each other, whereas on the other team there was a little more sarcasm and kind of maybe more negativity among the team. So you could see differences in the culture. And then when we looked at the structure of the teams, who did they have on their teams? What did it look like? The high recovery-oriented team had peer specialists on their team. So these were people in recovery doing well. They were full team members. They were at the morning meetings. They do the services. They're part of the team. The other teams did not have that role. In our state, it wasn't required. It wasn't part of the fidelity scale. But the high recovery teams did have a peer specialist. And what they would say is that having that person in the room really changes how you talk about people. It increases the level of respect in the language. And And the consumer could also bring in new ideas that teams hadn't really thought about before. So not only is it helpful for the clients to see a person in recovery doing well and kind of a role model, but it was very helpful for the staff to see and to work differently. On the high recovery team, the team leader really endorsed recovery concepts and really believed that recovery was possible. The other teams, not so much. They were less likely to really believe that people with mental illness could recover and meet their personal goals. We also saw more clinical skills on the high recovery team where they were using motivational interviewing. They were using other educational techniques that were more consistent with adult learning. They were also doing more of these other evidence-based practices, so teaching illness management. They were doing supported employment, integrated dual disorders. So they were doing much more of the therapeutic approaches we would like to see. And I had a conversation at lunch about the role of psychologists and how I think there you could see more psychologists doing some of these interventions too, for trauma-based care, for example, or cognitive behavioral therapy for psychosis. We see that now. You could do that on your ACT teams. And so I think having more of these clinical interventions can really help with recovery. We also saw differences in the environment. And I'm not an anthropologist, but I thought this was so cool. In the high recovery team, they had posters about recovery. They had their team mission was on the wall, kind of reminding everyone why we were here. And the other places had separate bathrooms for the staff and the clients. And the bathrooms were non-equivalent. So one had like the flowers and the nice stuff, and the other one was very bare. It didn't even have a mirror on the wall. So it was a very different environment. And even one of the clients who was working in the front office said she was so excited to get that job because then she could use the good bathroom. Like it was a special thing there. One of the sites had a lot of rules for the consumers. And this one was so interesting to me. In the waiting area, they had a soda machine, a pop, soft drinks, and then a sign that said no drinks in the waiting room. So well, you're offering drinks, but then you're telling people they can't drink them. So there was a lot of those kind of rules about what you could do. And even though it was a community mental health center, their waiting room had a locked door with a window like you would see in hospitals where you put the medications through in a community mental health center, where the high recovery team had a very open waiting room. Open, I could walk past the waiting room to anyone's staff office, and it was just all open in a much more trusting, welcoming environment. So these may be small things, but when you really look carefully, they can make a big difference in how you feel walking into one of those places. So those were interesting observations. And then the fourth one was really, how do we work with the clients? What is our process of making decisions? And a few of you were at Monday, I did a talk on shared decision making. So it's very similar concept of how do we identify what we want to do with our treatment and our goals, who's responsible, how do we talk about that. In the high recovery oriented teams, you would see the consumer's goals driving the treatment. Well, Joe wants to get a girlfriend. Medicaid doesn't pay to get a girlfriend, but Medicaid pays to reduce your symptoms that might help you get a girlfriend, or Medicaid might pay for your employment services that give you income to afford to go on a date. But you're really helping the person get what it is they want, even though you're billing for other clinical things that meet those needs. And in the low teams, we saw more of the staff driving. What are the goals? What should the treatment goals be? When does the team step in? And this is kind of related to that first point about trusting the consumers. So in the high recovery teams, they seem to trust consumers more. More of the consumers were managing their own medications, and then if they saw a person was having trouble with their medications, then they would step it up. They would come visit more often, or they would talk to them about the role of maybe the injectable medications and how that might help, so that you don't have to remember it all the time. That you could do it once a month instead of every day. The other team started everyone off on high medication monitoring. They either all had injectables or were being visited every day to make sure they had their medicines. And then they would say, when they could prove to us that they could manage their medicine, we'll step back. But how do you ever know that if you start everyone off on the highest level of care, right? So it was a very different philosophy of, do we trust them, and then if they get in trouble, we step in, versus we're going to control it from the beginning. So we can kind of think about that. And then how do you define risk? And this I had to learn a lot about, that we can't just come in and judge the low recovery teams for being bad, right? They have reasons why they did that. And when I could listen to them and hear about it, the lower recovery teams were in more rural areas. So they had fewer doctors. They had more close relationships with the police. Everyone knows everyone in that town. And so they felt like they had to protect relationships more than in our urban areas. So if a consumer caused problems visiting the primary care doctor in a rural area, that doctor might be not willing to see your other patients, and so there's a higher risk involved. Whereas if you're in an urban setting, if there's difficulty, you might be able to find another doctor or 10 other doctors who would see your clients. So you have to think about the risk benefits of this trust relationship. But the lower recovery-oriented teams were more risk averse. They didn't want to take risks because they felt like they couldn't. And then how does the team step in? So when you do need to provide more intensive care, what does that look like? And on the high recovery teams, they talked about having conversations with the consumer in the room and with the team, where they would say, hey, we have some concerns. We see you haven't been taking your medicine and you're getting more symptoms and that's interfering. We think we might need to step in. What are your thoughts about this? And have a conversation. And the other teams, it was more the team decides and then just does it. So I think there's a different way that you can think about, well, when we do need to provide more intensive care and be less recovery oriented, can you still do that in conjunction with the person? So those were some of the things. So I think for ACT, as a resolution, if we think about ACT as the structure to provide care and a way to organize services, then what we do on the ACT teams are the clinical interventions, the other things. Are we doing supported employment? Are we doing trauma-based therapy? Are we working with family members? Are we teaching illness management? And so if you can integrate ACT as a nice structure with other evidence-based practices, I think that you can do recovery-oriented care and still do the ACT model, that they can work. And if you work together on this idea of how providers and consumers can work together, so the sense about shared decision making and how do we come to treatment decisions together, and what can that look like. So some general challenges, I think, for the future for ACT. If you're going to be doing ACT, then what does what do your other services look like for non-ACT clients? So for the softer psychiatry or people who have depression and anxiety, but maybe they aren't going in and out of the hospital. What does that look like? So I think as a healthcare system, you need to think about the different types of service needs. You might need to show the business case. So are you having people who are in the hospital a lot or in the jails or in the prisons? Is there a reason that you need the ACT model? And so can you collect some data and show that this could be more cost effective or just more effective than what you're doing now? So making that business case. Can you use this model on other populations? So I think you had asked about substance users. And typically ACT has not been used for that group in particular unless they also have a dual diagnosis, so mental health. But there have been some people who've started to use ACT or ACT-like models for people with borderline personality disorder, for example. And so you might integrate. What they typically do is they use the structure, but they integrate dialectical behavior therapy. So you still have some limit setting and those kind of things. So it looks a little different, but they use the similar organization. We still need to figure out how to address employment well and social isolation. I think the risk of serving everyone in the community is if they're living in their own apartments. They don't necessarily meet their neighbors and develop those relationships. And so I think ACT teams could do a better job of that community integration and inclusion. And it seems like some of your programs that I heard about at lunch might actually be doing some of that better than some of our teams might have done. So that might be something to think about. And really getting a better understanding of long-term recovery. So trajectories of people with severe mental illness. There have been long-term studies that show that large groups of people can recover from severe mental illness. But there may be a large group of people who need these services for their lifetime, but maybe at varying degrees. And so do we do something like the function of ACT model that they do in the Netherlands, so that you have a core team, but you don't always have to have that intensive approach the whole time. So you might think about, would that work better here, for example. So I think in terms of kind of a summary of ACT, when I think about ACT as it's a very clearly defined model. We know what is supposed to go into ACT. ACT is shown to be very effective in a number of different studies. I showed you the 25 controlled studies together, but even since then other studies have been done. And we do have some evidence showing that higher fidelity is associated with better outcomes, so people who are actually following the model tend to have better outcomes. But it's hard to get these going. You have to really work at implementation, and I didn't put a lot of slides together on that, but I can talk for hours on setting up ACT teams and what that looks like. But it does take work. You can't just read an article and then go back to your office and say, now we're doing ACT. And I actually, maybe I could stop and say, before we get to the discussion, I do have a paper where we talk a little bit about our Technical Assistance Center and what we did. And we think about setting ACT teams up as 5 main steps, like if you decide here you want to do ACT. And really helping people know what are the explicit principles and guidelines. So you can use those fidelity scales to help people understand what are those elements, what will that look like. In Indiana, our state set up funding guidelines, like you had to meet these criteria and then you would get this amount of money. So setting up a policy around those specific guidelines and providing the supports for change so that if you do set up policies and funding, You have supports to help make it happen. So our state gave teams extra money to follow the ACT model. They also funded a technical assistance center where we worked with an agency that was already doing ACT well. And those people went out and did a lot of training to other mental health centers. We had centers visit each other. And so I know over here someone said they have an ACT-like team that they're doing. There may be other places that are doing something similar. Well, can you visit each other? Can you start talking and doing that? Providing some training. So our Technical Assistance Center would do trainings, like 2 full-day trainings, and then we would go visit programs and do coaching on site. We'd go out and visit people in the homes and then provide case managers some feedback. We'd spend time with team leaders. And we would go pretty intensively early on, maybe once a month. And then once the teams got up and going, we would go back every 6 months and visit them and provide some help. And then we also provided some kind of consultation. People could email us and call us, and our trainers could be involved. So having some kind of structure in place, if you're going to think about doing it as a country in multiple places, having some kind of network or system of support will be helpful. And then collecting some data on how it's working. And I say data on the process and the outcomes. Measure the fidelity. Are you really doing the ACT model, or have you changed it to something else? But then measuring to make sure that you're doing whatever it is you hope to be doing, and measuring your client outcomes. Are your teams affecting services and outcomes in the way you want them to be? So I think these are like the key things that if you decide you want to start implementing ACT or something like that, to really have in place to do it well. And Orion and I were talking about visiting and other opportunities. I'd be thrilled to come back and help with any of this process if you guys are looking towards doing that. So that would be exciting. But I will stop now and kind of go backwards and see. Maybe we could start with, are there questions, like clarifying things over the stuff I talked about the second half? And then we could move into more of an open discussion of what it would look like here if you would want. Yes?
About the medication. If the person doesn't want to take the medication, do the ACT team stop treating him, or what's the price of not taking medicine?
They would not stop treating him. So you can't just say, I don't want medicine, and then we don't see you anymore. Psychiatrists and all of the team members would try to support this decision and try to help think through this. Sometimes you could take a medication break and see what happens. That is high risk. Sometimes the psychiatrist doesn't want to do that because it's scary. They may be liable. But on the other hand, especially in community care, you can't force people to take medicine, right? They may not take it anyway. And so we really only have the illusion of control. So if we can talk to people about, well, what happened the last time you stopped taking the medicine? How did that work for you? And, trying to help them understand that process and look back. But sometimes we do need to let people make decisions that we might think are not good decisions, and then they have the consequences, and then they come back. But the team would try to support that and try to help the person through that and still serve them. Yeah. Yeah.
Slightly naughty question.
Okay.
What are the disadvantages of this model, this system? Do you have any personal criticism about the model? Because I, until now, heard the advantages, which are great.
Mm-hmm.
Do you think that there are disadvantages in comparison to other systems or models?
Well, I think that you could have the tendency to not support recovery. I think that because the structures are in place, that you're visiting people often, you're making sure they're on medications, it would be easy to slide into a paternalistic, controlling kind of team. But I don't think that that has to happen. I think we have seen these recovery-oriented teams that can do it well. So I think if you pay attention to those four elements, how you work with consumers, the environment, the culture, that I think that you can do it. So that would be my concern, would be that a team could easily move into more control rather than recovery. The other thing is the cost. And so I think you have to look at your system and who needs the care. Maybe there's one or two cities in Israel or a couple of places that could really use ACT teams, but other places might not need that level of intensity. Or maybe you could use the function of ACT teams. That could be helpful, where for a subgroup of people or at certain times in people's lives, you could pull together that ACT team. So I don't think it's like the perfect model, always. I think it really does depend on what your needs and the context. But I think it does have a lot of strengths. So, yes?
While developing an ACT center, do you have neighbors that are against the idea or having a real protest?
When we first started funding ACT in the state, there were some community mental health centers who said, we get good outcomes just like we're doing. We don't need you to tell us what to do. And our state said, well, that's fine. We just won't give you extra money for that. That if you're still getting good outcomes, you don't have to do ACT. But if you're going to choose to do ACT, our state gave them more money because it's more expensive. And then once the state provided that extra funding, those people said, hey, that looks like a good model. And they started doing it too. So I think the biggest concern was that fidelity versus outcomes. They don't want to be told how to do their services if they're getting good outcomes. But if they're not getting good outcomes, trying to follow fidelity might help them improve their outcomes.
What I meant was, when you have a center and you have people with mental illnesses coming and going, are the neighbors that live, I don't know where the centers are.
Oh, so the centers are already existing community mental health centers, but they're providing the services out in the community. So it's not like a group home, what we would call a group home, a residential facility where you would build a new building and bring all people with mental illness. It's not that. It would be as if this hospital decided, in addition to the hospital, we're going to do an ACT team and they're going to go out in the community and serve people who are already there. Yeah, so we don't have the...
NIMBY.
Yeah, NIMBY, not in my backyard. Yeah. We did have that when you tried to set up group homes and residential facilities. Yeah. Yes?
You mentioned earlier that you had in the new economy reduced from 30-something to 4 teams. Do you have any data of what happened to the patient, what happened to...
No, someone else asked me that too. We asked our state to provide us with the data so we could analyze it, and they did not choose to do that. So we don't know. Some of the mental health centers anecdotally said that they felt like their clients were still needing more care and that they weren't able to do that. But we don't have any hard data one way or the other. I would love to see that data though. And to see. Yeah. Yes?
You mentioned that it's effective from about 50 days of hospitalization a year.
Cost effective.
Cost effective.
Right.
Is there like a median model for like less days of annual hospitalization and less team members, or
Yeah.
like?
Unfortunately, the studies haven't been done to be able to dismantle like what is the minimum level you need for a certain amount of hospital use. So I really can't answer
or
that.
even the severity of symptoms, or like the הפרעה, נטל המחלה.
Yeah, different functioning levels.
The level of severity of dysfunction
Yeah.
or disability.
I don't have anything empirically that I could say at this level you only need 4 staff and 2 days a week, and at this level you need 10 staff and 5 days a week.
Or, or
I
maybe
don't know.
comparing to case management, other models.
Well, when you compare other models, they differ on so many domains that it's too hard to sort out what is the critical ingredient. So a lot of these ACT studies originally were compared to an individual case manager. Well, an individual case manager can't do shared caseloads, morning meetings, like all of those other things. So it's hard to sort out what are the key things you need.
I'm asking it because we were talking in the lunch break about the open dialogue between different services. Just me is from an occupational service, he's from an apartment, deal, and like the connection of information between us. It's kind of like an ACT team when it's working well.
Yes.
And it's much less costly.
Right. I had a similar conversation with someone and said, are the clients you're serving doing well? Are they meeting their goals? Are you helping them? And if so, maybe there's not a need to change. But if you have groups of clients who are not being served well, who maybe are having a lot of crises or ending up in hospitals for a long time or in the jail system, then maybe for those people you might need something different. So it does sound like some of what you do is like ACT, but you're not meeting every morning. You have good relationships, you know who to call.
Just the part of the communication.
Yeah, the communication.
And
So
also it's based on, you know, goodwill and the chemistry and the level of chemistry communication. It's not something that you have to do, that it's part of your ethic, that it's part of your...
yeah, so you might have some people you work really well with and you can make those easy connections, and other people not so much. And so an ACT team might help support more people or have more services available for the people. So I think it's interesting to hear what you're doing, and then where do you think part of this model might help? Are there gaps in the care that is happening now, maybe?